Hello and welcome to the Mental Health Book Club podcast with your hosts Sydney Timmins and Becky Lawrence. We would like to take this opportunity to let you know that we will be covering a diverse range of mental health topics that may be distressing to some listeners. You can find a full list of the topics being covered in each episode in the show notes. Please check the show notes before listening to any of our episodes. Welcome to the Mental Health Book Club podcast with me, Sydney Timmins. Today's episode is a deep dive into Obsessive Compulsive disorder as a result of us reading Am I Normal Yet by Holly Bourne. And this podcast will be discussing topics of self-harm briefly. But before we start, I'd just like to introduce myself. My name is Sydney Timmins. I am a writer and someone who suffers with my own issues with mental illness, which includes borderline personality disorder, depression, and anxiety. I am not a professional mental health practitioner of any kind, but I do have a deep interest in promoting mental health issues and trying to reduce the stigma by talking about mental health. And so the idea of this podcast was to start off by trying to add to that voice, which has gotten bigger in recent years, but there still is inequalities in the way that we deal with mental health issues. So that was the whole point of the podcast, because in essence, books and media that we read have an impact upon how we see different mental health illnesses. And I thought that maybe we should look at the ones that did a good job on portraying mental health and identify ones that weren't necessarily true to life. So the idea of these deep dive episodes was to add an additional element to the podcast so that you got a better understanding of the different mental health conditions. And to do this, I spend quite a lot of time doing research and finding everything that I can on the internet about the particular condition that we're talking about in the last book. I try to ensure that I use reputable sources, and what I'm doing is I'm compiling it into the blog post associated with the podcast, because I realised that the information I was giving there was quite a lot, and if you wanted to revisit it at any time, you now can. So accompanying this particular podcast episode, the show notes and the blog post will contain information of what I'm going to be discussing with you today. I also thought it would be a really nice thing to do as it's beginning of 2018 is to identify the goals that I have for this podcast going forward. It means that way I'm going to have this recording to look back on and identify if we actually have met the goals that I set out today. So my goal for 2017 was to start the podcast, which I can successfully say that we definitely did that. Going forward, the first thing that I want to try and do is increase our mailing list. And by doing that, I want to offer you guys something in return for signing up. So what I've decided to do is that if you sign up to the mailing list, you will receive a compiled document with all of the different blog posts that include all of the different information and the sources of where I got that information as a download when you sign up. And because this information is going to be added to over the course of a year, I will ensure that every 3 months there will be an update for you to download, and I will email that out so that you can then have a more comprehensive list of all of the topics that we've covered in this podcast. There's no point in you signing up to our mailing list and not getting anything really back in return. You're giving me something, which is your email address, so therefore I'm going to give you something back. So instead of having to trawl through all of our blog posts on our website, you'll be able to get it all in one place. The second thing that I'd like to do this year, other than continuing the podcast, which is a given really, is to increase our offering on Patreon. So Patreon is a way that you can support the podcast financially by giving as little as $2 a month towards the running costs of the Mental Health Book Club podcast. Once we reach a certain figure, and I've changed the different levels now that I'm aiming for, so once we hit our first goal of $200 per month, we will then be able to give a donation to Mind, the mental health charity, because they are one of the places that I get quite a lot of information from for doing this particular podcast. And there are different levels, so there are targets of $200, $400, $600, $800 and $1,000. If we ever get to those, I'll be extremely grateful to you all, but it also means that we'll be able to support more mental health charities. So not only would you be supporting the Mental Health Book Club podcast, but you'd also be supporting charities in the UK for mental health. So if you think that you'll be able to participate in that donation, please head over to patreon.com/MHBC. In relation to Patreon, what I would like to also do is increase the offering that we have. So at the moment we do have a patron-only feed that releases early episodes associated with the books that we review. But what I would also like to do is add additional episodes that will be bonuses purely for those that have become patrons of the podcast. So if you happen to follow the Mental Health Book Club podcast on Twitter, you will have noticed that both myself and Becky have been struggling with our own mental health this festive season. And so myself and Becky recorded a special episode specifically for patrons discussing her mental health and her views and how she was treated by the National Health Service in the UK. I also self-harmed for the first time in 4 years over the Christmas period, and so I think I'm going to do another episode about how that came about and what caused me to self-harm again after 4 years, and the impacts that's had on my life as a result of feeling in some ways like I had beaten it, but unfortunately giving in to the urges that I experience on a day-to-day basis. I would also like to increase the offering to the gold members of Patreon, and any suggestions would be highly welcomed. If you still want to support the podcast but you're unable to do so financially, that's not a problem. You still can, and we appreciate any help that you can give us. But what you can do is head on over to Twitter and Facebook and like and follow our pages. So for Twitter, the Twitter handle is MHBC_podcast. And if you go into Facebook, you just need to search Mental Health Book Club podcast and our page should appear. Also, telling your friends and family if you enjoyed the podcast would be amazing. So any mentions of the podcast and suggesting that they listen would be fantastic. You can leave us a review wherever you get your podcasts, so that could be iTunes or Stitcher. And if you have any comments, please just send us an email or tweet us or send us a message on Facebook. We would really love to hear from you. You can also email us or fill in the contact form on our website, which is mentalhealthbookclub.com. If there is anything that you can think of that will make this podcast better, again, please just let us know. We're here to listen and to hopefully respond to the things that you say. So that's kind of everything that I wanted to say. So let's get into looking at obsessive compulsive disorder. So I found some fantastic websites out there with a whole heap of information about obsessive compulsive disorder. One such place was helpguide.org and the International OCD Foundation, and both of those had some fantastic information, and the latter, so the International Obsessive Compulsive Disorder Foundation, had an example of what it is like and what happens to be going through a person's mind when they have obsessive compulsive disorder. So imagine that your mind gets stuck on a particular thought or image, and that is known as the obsessive thought. Then this thought or image gets constantly replayed in your mind, over and over and over again, no matter what you do. It's not like you want these thoughts. It feels like an avalanche. It's overwhelming. Along with these thoughts, you start to have intense feelings of anxiety. And anxiety is a normal emotion that people feel, because this emotion tells you to respond, react, protect yourself, and do something to reduce this anxiety. It's our brain's warning system, indicating that you're in danger. But, in certain cases, your brain is lying to you, causing you to question why this would be happening. Why would you be experiencing feelings if they weren't true? Feelings don't lie, but unfortunately they do. So, for example, there are people that have issues with contamination, and they are identified as washers. So washers are afraid of contamination. They usually have cleaning or hand-washing compulsions. There are checkers, so those are people that repeatedly check things. Is the oven turned off? Is the door locked? And then they associate that with danger or harm. Doubters or sinners, who are afraid that if everything isn't perfect or done just right, something terrible will happen, or they will be punished. Counters and arrangers, they're obsessed with order and symmetry, and they may have superstitions about certain numbers, colours, or arrangements. And there is also hoarders, and hoarders fear that something bad will happen if they throw anything away. They compulsively hoard things that they don't need or use. Unfortunately, if you have OCD, your brain is lying to you. The warning system in your brain is not working correctly, and your brain is telling you that there is danger when there isn't any. And what scientists have found that when they look at pictures of the brain, so probably taken by an MRI machine, that people that have OCD have, on average, some areas of the brain that are different when compared to individuals who don't have OCD. Those tortured with this disorder are desperately trying to get away from the paralysing, unending anxiety. And so people who suffer from OCD end up in this vicious cycle where they start off with an obsessive thought, which then creates anxiety, which leads to the compulsive behaviour that then offers temporary relief, and then the cycle starts all over again. Whilst researching OCD, I did find some interesting statistics associated with the prevalence of the disorder. So worldwide, there is literally millions of people that are affected by OCD, and it's considered the fourth most common mental health illness in many Western countries. It affects all people equally, so there is no difference between men, women and children, and there is no difference in race, religion, nationality or social-economic group. So I've got some specific statistics from the United States and the United Kingdom. So in the US, the best estimates for the USA are about 1 in 100 adults. Or, in reality, in terms of the numbers, it's between 2 to 3 million adults who are currently suffering with OCD. This is roughly the same number of people living in the city of Houston, Texas. And although I don't come from the United States, I think Houston, Texas is pretty big. There are also at least 1 in 200, or in terms of the numbers, 500,000 kids and teenagers who are suffering with OCD. And this is about the same number of kids who have diabetes. In terms of prevalence at schools, 4 or 5 kids in any average-sized elementary school will have been diagnosed with OCD. In a medium to large school, there could be as many as 20 students struggling with the challenges of OCD. In the United Kingdom, current estimates suggest that 1.2% of the population are suffering with OCD, and that equates to 12 out of every 1,000 people. And so, in terms of the numbers, that's approximately 741,504 people in the UK living with OCD at any one time. Out of those cases, 50% of them fall into the severe category, and less than a quarter are classified as having mild cases. These estimates are still considered to be underestimated, and many people affected with OCD suffer in silence. And this is because of the embarrassment and the fear of being labelled with the term OCD. There are also a lot of people out there that are unaware that their suffering is a recognised medical condition, and as a result don't seek the help that they need. So what are the symptoms of OCD? So I'm going to distinguish between what is considered normal and then what is considered to be an obsessive compulsive disorder type symptom. So most of people at any time will have worries. They'll have doubts, they'll have superstitious beliefs that if they do certain things in a certain way, something good will happen. Or if they don't do something, then something bad might happen. For example, when you are saying something that you're hopeful about, you have the saying, "Oh, touch wood." But the thing is, it's only when those thoughts and behaviours start to make no sense to other people around you, if those thoughts and behaviours cause distress, or they become excessive, that you may want to ask for help, because that isn't normal. It's important to note that OCD can occur at any stage in your life. It's not usually identified with specific age groups, so it can occur at any time, but there are certain groups that are more prone to it than others, and so that is when you are in your early life, so childhood, and also in your teens to early adulthood. So what is an obsession? So from my research, an obsession is an unwelcome thought or image that you keep thinking about and is largely out of your control. And these can be difficult to ignore, so you're unable to put that thought to one side and continue with your daily life. These obsessions can be disturbing and are accompanied by intense and uncomfortable feelings such as fear, disgust, doubt, or a feeling that things have to be done in a way that is just right or something bad will happen. OCD obsessions are time consuming, and so they get in the way of other important activities and day-to-day life, and so that really is the determiner of whether the person is suffering from OCD. So if you are having intrusive thoughts but it's not really impacting your day-to-day life, then it would just be what is considered normal. However, if it stops you from getting to work on time, or if it stops you from leaving the house, then that's when things are moving towards it being more of an obsessive compulsive disorder, rather than just obsessive personality traits. These obsessions also cause the person to think that something bad will happen if they don't do the things that they are thinking about, and the person with OCD will often realise that these behaviours and this way of thinking isn't logical, but they can't stop it. So that leads us on to what an obsession isn't. So an obsession isn't an occasional thought about getting sick or about the safety of loved ones, because that is just normal. Even if the content of that obsession is more serious, so for example, everyone might have had a thought from time to time that if they don't wash their hands, they're going to get sick, and that they're going to cause everyone else in their household to get sick. Or if you're worrying about a loved one's safety, or you're wondering if a mistake that you made might be catastrophic in some way, those are not considered obsessions associated with OCD. While those thoughts look the same as what you would see in OCD, someone without OCD may have these thoughts, but they momentarily are concerned with them and then they move on, so they don't necessarily dwell on the obsessive thought that has popped into their mind. And in fact, research has shown that most people have unwanted, intrusive thoughts from time to time. But in the context of OCD, these intrusive thoughts become frequent and trigger extreme anxiety, and that's what's getting in the way of their day-to-day functioning. Just as a little side note, I'd just like to go into the misuse of language that we are often prone to do. So, for example, in everyday language, we may use the term that we're obsessing or we're being obsessed by something, and it's common. However, the casual use of this word means that someone is just preoccupied with a particular topic or an idea or even a person. When someone says that they're obsessed in an everyday setting, it doesn't mean that they have problems with their day-to-day living as a result of the particular obsession that they're having, and that obsession could even be classified as pleasurable. So for example, you can be obsessed with a new song, a new TV series where you've gone and binge watched it all, a podcast, a new food that you found. But because of those things, it doesn't mean that as a result you can't go out and meet your friends for dinner, you can't get ready for bed in a timely fashion, you can't get out to work on time in the morning. And in fact, individuals with OCD have a hard time hearing this usage of obsession. And the reason for this is because it can feel like the rest of us are diminishing the struggles with OCD symptoms. And if you're stuck in that loop and you have so much anxiety associated with not doing certain things in a certain way, it can be debilitating. And yet, as a society, we may misuse the word obsession. So compulsion in OCD. A compulsion is something you think about or do repeatedly. So that's the repetitive behaviour aspect of OCD. And that repetitive behaviour can help to relieve anxiety temporarily. These compulsions can be hidden or very obvious. So for example, some people find that their anxiety is reduced by saying a particular phrase in their head to calm themselves down, or that they check the front door is locked repeatedly, so that's more visual and we can see that. People with OCD are aware that they will only experience temporary relief, as I stated, and that the compulsion is not a solution, but the problem is for them is that they feel that they don't have a better way to cope. So as I said, even if it feels like you have this temporary relief, you have to keep doing the same activity over again. A compulsion can also include avoiding certain situations that will trigger obsessions. Compulsions are time-consuming and get in the way of day-to-day life. And in most cases, individuals with OCD feel driven to engage in compulsive behaviour and would rather not have to do these time-consuming things. And those compulsions can become torturing acts of behaviour to that individual. So what are compulsions not? Firstly, it's important to note that not all repetitive behaviours or rituals are compulsions. So for example, you may have a set bedtime routine. You may have set religious practices. And as a result of learning a new skill, you may have to repeat an activity over and over again for it to become solidified in your mind. But these are welcome parts of everyday life. These are the things that we do because we need to do them to survive. However, compulsions are not like this. And in OCD, the behaviours are depending on the function and context. So for example, if you spend hours and hours arranging and ordering DVDs, so say for 8 hours a day, it isn't a compulsion if you work in a video store. Also, arranging and ordering books for 8 hours a day isn't a compulsion if that person works in a library. An example for me is that when I worked in retail, I like to have all of the hangers, the tops of the hanger, the hook, all on the racks in the same direction. And whilst that could be considered a compulsion if that was just me at home doing that for hours on end, it was just part of my job. That was just one of the things that was expected of me to do. Similarly, if you have certain behaviours that may look like compulsions, it might just be the fact that you're a stickler for details or like to have things neatly arranged in a particular way. So in that particular respect, the compulsive behaviour or the compulsion here is referring to a personality trait or something about yourself that you actually prefer or like. So I found this great resource that I shall put up onto the blog post about what are some of the common obsessions and compulsions that an individual with OCD may suffer from. That leads us into how do we diagnose OCD. And so like all other mental health conditions that we discuss on this podcast, an individual can only be diagnosed by a trained medical professional. There are no blood tests, there's no brain imaging test that can be used to diagnose OCD, and it's a case of that the diagnosis is made based on the observation and assessment of the person's symptoms. There are also certain problems that are associated with having OCD, so additional mental health problems that come hand in hand. So some people with OCD may also develop other serious mental health conditions such as depression, an eating disorder, which we see in Am I Normal Yet? Because she's misdiagnosed with anorexia, generalised anxiety disorder, and hoarding disorders. And as a result of those, the person may feel suicidal. So in terms of the DSM-5, the diagnostic criteria for obsessive compulsive disorder is the presence of obsessions compulsions, or both. And the DSM-5 defines obsessions as 1. The recurrent and persistent thoughts, urges, or impulses that are experienced at some time during the disturbance as intrusive and unwanted, and that in most individual cases marked anxiety or distress. And 2. The individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action, i.e. by performing a compulsion. A compulsion is defined as 1. Repetitive behaviours, e.g. hand washing, ordering, checking, or mental acts, e.g. praying, counting, repeating words silently, that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. 2. The behaviours or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviours or mental acts are not connected in a realistic way with what they are designed to neutralise or prevent, or are clearly excessive. And the DSM has a note here that young children may not be able to articulate the aims of these behaviours or mental acts. So that would be up to the medical professional to identify whether they are doing it for a particular reason or not. B. The obsession or compulsions are time-consuming, so they take more than 1 hour per day, or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. C. The obsessive compulsive symptoms are not attributable to the physiological effects of a substance, so that includes drug abuse or a medication or another medical condition. D. The disturbance is not better explained by the symptoms of another mental disorder, e.g. excessive worries as in generalized anxiety disorder, preoccupation with appearance as in body dysmorphic disorder, difficulty discarding or parting with possessions as in hoarding disorder, hair pulling as in trichotillomania, skin picking as in exoration disorder, stereotypies as in stereotypic movement disorder, ritualized eating behavior as in eating disorders, preoccupation with substances or gambling as in a substance-related and addictive disorders, preoccupation with having an illness as in illness anxiety disorder, sexual urges or fantasies as in paraphilic disorders, impulses as in disruptive impulse control and conduct disorders, guilty ruminations as in major depressive disorder, thought insertion or delusional preoccupations as in schizophrenia spectrum and other psychotic disorders, or repetitive patterns or behaviour as in autism spectrum disorder. The DSM also specifies that the mental health practitioner needs to record whether the individual has good or fair insight, so that the individual recognises that the obsessive compulsive disorder beliefs are definitely or probably not true, or that they may or may not be true, whether they have poor insight, so the individual thinks obsessive compulsive disorder beliefs are probably true, or with absent insight or delusional beliefs, so the individual is completely convinced that obsessive compulsive disorder beliefs are true. The DSM also says that you need to specify if there is a tic related to the obsession compulsive disorder, so the individual has a current or past history of tic disorder. In terms of the ICD-10, there are several different classifications that an individual could be placed into, and so, as I said before, the ICD-10, the main purpose of that is for reimbursement associated with American healthcare systems and insurances purposes. And so this comes from the 2018 edition of the ICD-10, that there are some exclusions from putting someone in the category of having obsessive compulsive disorder, which includes obsessive compulsive personality disorder, which has its own classification, obsessive compulsive symptoms occurring in depression, which has its own classification, and obsessive compulsive symptoms occurring in schizophrenia. So the ICD-10 identifies the clinical information for this disorder as a disorder characterised by the presence of pre-existing and recurrent irrational thoughts, obsessions, resulted in marked anxiety and repetitive excessive behaviours, compulsions as a way to decrease that anxiety. An anxiety disorder characterised by recurrent, persistent obsessions or compulsions. Obsessions are the intrusive ideas, thoughts or images that are experienced as senseless or repugnant. Compulsions are repetitive and seemingly purposeful behaviour which the individual generally recognises as senseless and from which the individual does not derive pleasure, although it may provide a release from tension. An anxiety disorder in which a person has intrusive ideas, thoughts or images that occur repeatedly and in which he or she feels driven to perform certain behaviours over and over again. For example, a person may worry all the time about germs and so will wash hands over and over again. Having an obsessive compulsive disorder may cause a person to have trouble carrying out daily activities. It is a disorder that is characterised by recurrent obsessions or compulsions that may interfere with the individual's daily functioning or serve as a source of distress. And obsessive compulsive disorder is a type of anxiety disorder. If you have OCD, you have repeated upsetting thoughts called obsessions. You do the same thing over and over again to try to make the thoughts go away. These repeated actions are called compulsions. Examples of obsessions are a fear of germs or a fear of being hurt. A compulsion includes washing your hands, counting, checking on things, or cleaning. If untreated, OCD can take over a person's life, and researchers think that the brain circuits may not work properly in people who have OCD. It does tend to run in families. The symptoms often begin in childhood or teens, and treatments that combine medicines and therapy are often effective. So what causes OCD? Well, this is pretty complicated, as with other mental health conditions, that they're not really sure what specifically causes OCD, but there are a variety of factors. One is the family history. So research has shown that you are more likely to develop OCD if a family member has it, possibly because of your genes, but these have been shown to only be partly responsible for the onset of OCD. There's also differences in the brain, so some people with OCD have areas of unusually high activity in their brain or low levels of a chemical called serotonin. And research suggests that OCD involves problems in communication between the front part of the brain and the deeper structures. And pictures of the brain at work also show that in some people, the brain circuits involved in OCD become more normal with either serotonin medicines or cognitive behaviour therapy. OCD can be caused by life events and may be common in people who have experienced bullying, abuse or neglect. And it sometimes starts after an important life event such as childbirth or bereavement. It could be as a result of a person's personality. So their personality may be that they're neat, meticulous, methodical people with high personal standards. And as a result of that, they may be more likely to develop OCD. And as many of those who are generally quite anxious or have a very strong sense of responsibility for themselves and others, it's just one of their personality traits. Also, the time of onset. Some experts think that OCD begins in childhood may be different from the OCD that begins in adults. For example, a recent review of twin studies showed that genes play a larger role when OCD starts in childhood, so that's 45 to 65%, compared to when it starts in adulthood, which is 27 to 47%. So how can OCD be treated? And it can be treated, and it's important that people do go and get the help that they need. And so studies have found that it can take, on average, approximately 14 to 17 years from the onset of OCD symptoms before the person actually obtains appropriate treatment. And this could be because of a variety of factors. And one of those factors is stigma. And so people choose to hide their symptoms because they have this fear and embarrassment associated with the stigma of being labelled someone with OCD. So many people don't seek the help from mental health professionals that they need until they have spent many years suffering from the symptoms associated with OCD. Other reasons that people may not seek out the help that they need is because of a lack of public awareness of what OCD actually is. However, I think this is getting better, and the more we talk about these different health conditions, the more people are going to be able to identify that there is a problem. but it's thought that many people were unaware that their symptoms represented an illness that could be treated. There's also a lack of proper training by some health professionals, which can lead to the wrong diagnosis, as we saw in Am I Normal Yet? So some people who have OCD symptoms will see several doctors and spend several years in treatment before receiving the correct diagnosis for the condition that they have. There may be issues in finding local therapists who can be effective in treating OCD, and in certain parts of the world it may be because that individual is unable to pay for the treatment that they require. So that's mainly an issue in countries where you are responsible for paying for your own healthcare. However, in the NHS, this could be as a result of a lack of funding and being unable to access the care that you need, and your decision to go private. And if you can't go private, then you have issues because you're not being effectively treated for your OCD. There is also the stigma from mental health professionals themselves. So the medical profession in the past has considered OCD as a bizarre condition, and as such assumed it to be very rare. Also that families can be reluctant to talk about OCD due to the stigma. And it's clear that OCD will have an effect on the sufferer, but it can also be difficult to understand the effect it can have on the individual's families. And so OCD, what you really need to remember is that OCD is all-encompassing and all family members are inextricably involved with the sufferer's illness. It's in some ways another one of those mental health issues that will impact others around you. So in the UK, the way that you can get help for OCD is to visit your GP, explain your symptoms to your GP, and they will then refer you to a local psychological therapy service if they deem it necessary. Alternatively, you can now self-refer yourself to a psychological therapy service, and I'll put a link in the show notes so that you can find out what is available in your local area and who is accepting self-referrals. For those of you that think that you may have a friend or family member with OCD, the first step is to try talking to them about your concerns and then suggest that they seek help. And it's important to note that if the person has OCD, then it is very unlikely to get better without proper treatment and support. So in the UK, the main treatments are psychological therapy, and that is a special type of cognitive behaviour therapy identified as exposure and response prevention. And this type of therapy helps the individual face fears and the obsessive thoughts without putting them with the compulsions that you are used to doing. So you work with your therapist to break down your problems into their separate parts. So you break it down into the thoughts, the physical feelings, and then the actions that you face to deal with the physical feelings. The individual is encouraged to face their fear and let the obsessive thoughts occur without neutralising them with the compulsive behaviours. And so you start off with situations that cause you the least anxiety first, and then you move on to more difficult ones. But this treatment is difficult, and it also may sound frightening for many people, but when they confront their obsessions, their anxiety does eventually improve or go away. It is thought that people with fairly mild OCD will usually need about 10 hours of a therapist treatment, and this is done with exercises done at home between sessions. A longer course may be necessary in more severe cases. OCD can also be treated with medications, so if psychological therapy doesn't help to treat the OCD, or if the OCD is fairly severe, and so these are usually done with antidepressants, such as selective serotonin reuptake inhibitors, and these can increase your levels of serotonin in your brain, and so some examples of the medication that could be used is sertraline or Zoloft, paroxetine, Paxil, fluvoxamine, Lurvax, fluoxetine, Prozac, or citalopram, Celax. Now, I've probably butchered all of those, so I wouldn't necessarily rely on my pronunciations. So if you are started on these medications, you may need to take the medication for up to 12 weeks before you start to notice any effect on you. Most people require treatment for at least a year, and you may be able to stop it if you have few or no troublesome symptoms after this time. Although some people need to take medication for many years, your symptoms may continue to improve for up to 2 years of treatment. And so we see this in Am I Normal Yet?, where she tries to decrease the medication that she's taking, and as a result, her obsessions and compulsions increase again. It's important to note that if you are taking SSRIs or any medication associated with your mental health, don't stop taking it, because there are lots of side effects. You need to speak to your doctor first, and they can help you reduce the dose gradually. The problem with medication is that there are actually quite a lot of side effects. And so some of the possible side effects of SSRIs are feeling agitated, shaky or anxious, feeling or being sick, diarrhea or constipation, dizziness, sleeping problems, and headaches, and a low sex drive. There's also a very small chance that SSRIs could cause you to have suicidal thoughts or wants to self-harm. And if this occurs, you need to either see your GP straight away or get to A&E straight away. Most of these side effects will improve after a few weeks as your body adjusts to the medication, but sometimes these side effects can persist. In the UK, there are some options for further treatment, so you may be referred to a specialist team to treat your OCD if it's still not under control after psychological therapy and medication. And some people with severe, long-term and difficult to treat OCD may be referred to a national OCD service. And this service offers assessment and treatment to people with OCD who haven't responded to any of the treatments that are ordinarily available at the local level. And so if you are to be eligible for this service, you must have been diagnosed as having severe OCD and have received treatment with at least 2 different SSRIs at recommended doses for at least 3 months. There must have been at least 2 attempts at psychological therapy, both in a clinic and at home. An additional treatment with another medication, such as a different type of antidepressant called clomipramine, or an SSRI at a dose higher than normally recommended. And if you meet that criteria, that is when you will be referred on. In my research, I also found that there are also some types of psychosurgery that can be done to help relieve symptoms of OCD. And I shall put some pictures into the blog post. And to begin with, I only found these listed in America. However, after some Googling, you gotta love Google, I found that there is information about these from UK sources, but I don't necessarily know how prevalent these are offered to people in the UK. But the psychosurgery is used to alleviate symptoms of OCD in patients that haven't responded to the medications and the behaviour therapies. And so there are 4 different types of surgery that can be done for people with OCD. And one of those is anterior sigillotomy, and I probably have butchered that as well. And that involves drilling into the skull and burning an area of the brain called the anterior cingulate cortex with a heated probe. This surgery has provided benefits for 50% of those with treatment-resistant OCD. The next type of surgery is called anterior capsulotomy, which is similar to anterior sigillotomy surgery, but doctors operate to a different area of the brain called the anterior limb of the internal capsule, and this surgery has succeeded in giving relief to 50 to 60% of patients with treatment-resistant OCD. There is also something called the gamma knife, and this treatment does not involve opening the patient's skull, but rather the skull is penetrated by multiple doses of gamma rays, and while a single dose of gamma rays will not harm brain tissue, when multiple sources of the gamma rays are applied, they create an energy level adequate to destroy targeted brain tissue. And so the gamma knife procedure has been helpful to about 60% of treatment-resistant OCD patients. And the final surgery that a person with treatment-resistant OCD can undertake is something called deep brain stimulation. And although this procedure requires opening the patient's skull, it does not involve destroying any of the brain tissue like the other surgeries have. And instead, electrodes are placed at strategic points inside the brain and wired to a pulse generator. And the battery-powered generator, also called an implantable neurostimulator, sends pulses to the brain, and it works in a similar fashion to a pacemaker. and so far only small studies have been conducted with deep brain stimulation, but the response rate is similar to the other surgeries. So the final section that I'd like to cover is if you are out there trying to support someone who has OCD. And as I said before, families and friends associated with someone with OCD will inevitably be impacted. And there are plenty of things that you can do to try and support them. So I've got a numbered list, and these are just suggestions. And again, I will give you the references as to where I took these suggestions from. But the first is do not regard OCD as the person's fault and try not to believe that you or anyone else may have caused it. Unfortunately, it's easy for us to blame ourselves for the situation that someone else is in, particularly if you're a parent or a guardian. And if the person decides to seek professional help, try and be supportive of their decision and encourage them to continue with their determination to recover. It's important that you help your family member find the right treatment for them, and that the best treatment usually includes a combination of medicine, cognitive behaviour therapy, family education and support. 2. Encourage the person with OCD to persist with that treatment because they may find it extremely difficult, particularly if you listen to the part about the specialised cognitive behaviour therapy where the person's going to be basically forced to face their fears. They may find it really challenging and will try and escape from it, which is fair enough. And so try and show them the appreciation of any improvement that you see within them, however small that is, because that will help keep them encouraged to continue. 3. Sometimes that family member may decide that treatment isn't for them, and as a result you may need to learn how to respond to that family member's refusal of treatment. So the best idea is to be compassionate and not get angry with them, because you're less likely to get them to go back to treatment. There are some strategies that you can employ to try and encourage them to go back to treatment, and those are you could bring books, videotapes and audio tapes on OCD into the house, offering them information so that they have access to it, so that they can listen and read and research on their own. You can offer them encouragement, so you can tell the person that through proper treatment most people have a significant decrease in symptoms. Tell them that there is help and that there are others out there that have the same problems and are also struggling. Suggest that the person with OCD attends support groups, and I'm going to put a list of support groups into the show notes for you. And you can suggest that that is with or without you. You don't necessarily have to go with them. You can also suggest that they speak to a professional in a local OCD clinic if there are any available. Number 4, remember the symptoms may wax and wane over time. There will be good days and there will be really bad days, and it's important not to dwell on the bad days. Each person needs to overcome their own problems at their own pace, so don't expect instant results, and also don't demand and expect results from the individual suffering from OCD. Number 5, learn as much as you can about OCD, so educate yourself. And education is the key to helping someone with OCD. Read books on OCD, join support groups, attend support groups, research online. There's so much stuff out there that you can do to help someone who is suffering from OCD. Number 6, encourage your family member or friend to tell you and explain to you how it feels to have OCD. Having this particular mental health condition, and all mental health conditions out there, makes you feel very isolated, because not everyone is going to understand what it is that you're going through. But you can help reduce the shame associated with the condition by just listening to them and understanding what they're going through. And even though the compulsions that you witness seem unrealistic and irrational, you need to remember that this person is experiencing immense fear that if they don't complete these, something awful is going to happen. Number 7, while supporting the person with OCD, try not to support the obsessions and compulsions that they exhibit. So, for example, the International OCD Foundation calls this as you recognising and reducing family accommodating behaviours. And what they mean by family accommodating behaviours, these are the things that families do that help enable the person continue with their OCD symptoms. So because families are constantly affected by the demands of OCD, research has shown that how a family responds to the OCD may help fuel the OCD symptoms. So the more that the family members can learn about their responses to OCD and the impact they have on the person with OCD, the more the family becomes empowered to make a difference. And that's the key. It's making even the smallest of differences to help that person. And so here are some examples of the things that are problematic and that have been shown within families. So the family may participate in the behaviour itself. So for example, your participation in your family member's OCD behaviour along with them, for example, hand washing whenever they wash their hands, can have a negative impact. You can assist in the avoidance of certain things. So for example, you help your family member avoid things that upset them. So for example, doing the laundry for them so that it is cleaned the right way. You can also help with the behaviour. So you do things for your family member that lets them do the OCD behaviours. So for example, you buy large amounts of cleaning products for them so that they can continue their obsession with cleaning. You make changes and accommodations to your family routine. So for example, you change the time of day that you shower or when you change your clothes to allow the person with OCD to continue with their obsessions. You might decide that by taking on extra responsibilities, you are helping the person with OCD. So for example, going out of your way to drive them places when they could otherwise drive themselves, again is accommodating the behaviour that is associated with OCD. You may have decided to change your leisure activities as a result of the OCD. And finally, you may have made changes to your job. So for example, working shorter hours so that you can take care of the family member who is suffering from OCD. At this point, I found this information and I found this very interesting, that the worst thing that you can do for the person with OCD is to give them reassurances that their fears are unfounded. So if you keep telling them that these things are just silly and that they're not going to result in the things that they think are going to happen, is not going to be the thing that helps them. What you need to do is encourage the person with OCD to challenge those obsessions and compulsions and see for themselves that the thing that they are worried about isn't going to happen. Number 8. People with OCD are often aware of the humorous aspects of their obsessions and compulsions, and so this awareness can be used to help them distance themselves from the condition. However, try not to mock them. So when you get to the point where you're starting to mock the individual and their symptoms, this can cause additional stress, shame and embarrassment, which you don't want to cause. Number 9. At home, people with OCD should be encouraged to maintain as normal a lifestyle as possible. And as we said previously, families should resist the urge to change and accommodate the things for the person's obsession and compulsions. And number 10, remember that OCD is tough for families to deal with. You all need to continue to communicate with each other. Remember also that the family, friends and carers of people with OCD need help and support too, and you need to worry about yourselves just as much as you worry about the person with OCD. And so that really concludes everything I have found on OCD. There's a whole heap of information out there that you could go and delve into. As I said before, I'll put all of this information onto the Mental Health Book Club podcast website with the associated blog that will come with this episode. We really appreciate you listening. Thank you so much for supporting us. We hope that we are going to have a successful 2018 and that you will be able to have an equally successful 2018. And we look forward to talking to you guys next week. And the book next week will be The Quiet Room by Laurie Schiller. And don't forget, if you enjoyed our podcast, please head over to wherever you get your podcasts and leave us a review. Have a fantastic week, and we'll speak to you soon. Thanks for listening to this episode of the Mental Health Book Club podcast. If you feel that you need additional support with your mental health, please call the Samaritans on 116 123, which is a 24-hour helpline. And if you need additional information about mental health issues, please visit Mind at mind.org.uk. Our next book will be Quiet Room by Laurie Schiller. You can find out more by visiting our website, which is mentalhealthbookclub.com. We would really love to hear what you think about this podcast. Please get in touch with us at our Facebook page, which is the Mental Health Book Club, or at our Twitter, which is at MHBC_podcast. And if you like the podcast, please share it with your family and friends and leave us a 5-star rating on iTunes or wherever you get your podcasts. You can further show your support by contributing to the Mental Health Book Club podcast at Patreon by visiting patreon.com/MHBC.